All right. Well, welcome everybody. And I'm going to talk with you about ADHD in children and adults. Um, just want to start by mentioning my disclosures. I consult to several companies that provide ADHD products and services, and to a pharmacogenetics company. And I won't be referring to any specific products in this presentation. What I'm going to do today is first talk about what is ADHD, and I'm going to review the history and some lessons learned, my own kind of factor analysis of 60 years of research, and then talk about treatment, kind of lessons learned, and then describe some new directions and some new studies. Does everybody know who this is? This is Dr. Heinrich Hoffmann, and he wrote a children's book that it gives one of the first vivid descriptions of ADHD. The book was called Der Strumpffelter, and let me read you a little bit about this guy. This is Fidgety Phil. Let me see if Philip can be a little gentleman. Let me see if he is able to sit still for once at the table. Thus bade Papa Phil behave, and Mama looked very grave. But Fidgety Phil, he won't sit still. He wiggles and giggles, and then I declare swings backwards and forwards and tilts up in his chair, just like any rocking horse. Philip, I am getting cross. See the nasty, restless child growing still more rude and wild, till his chair falls over quite. So in that description, you can hear some of the symptoms of ADHD. The hyperactivity, the difficulty sustaining attention during meals. And you see Fidgety Phil there on the chair that's tilted. About a third of kids with ADHD have developmental coordination disorder, so it's not unusual for him to fall. And look at the expression on the parents' faces. How hard it is to have a child that's going to fall over, that is so taxing. And not surprising, we see such high rates of depression and so many family conflicts in families of kids with ADHD. So what is ADHD? When we talk about it, we often talk about symptoms. And think about it as two classes of symptoms: the hyperactivity, impulsive symptoms, and the attention symptoms. And so these are the lists of ADHD symptoms that were really developed mainly from studies of children. And we say someone meets the symptom criteria for ADHD when they have a certain number of these symptoms and they're developmentally inappropriate. Everybody has these symptoms from time to time, and so not everybody has ADHD. But if you have these symptoms and they're causing you difficulties, then ADHD is one of the things to think about or to consider. So again, having the symptoms isn't the same thing as having the disorder. It's just kind of one of the places to start. But ADHD is a disorder. It's a psychiatric disorder defined by DSM-5. And what are the characteristics of the disorder? Again, having these symptoms that are developmentally inappropriate, and the symptoms have to be present for at least 6 months. So, somebody that just has them for a short period of time, like classically when there's family dysfunction or stress or change or trauma, that's not the same thing as ADHD. But having the symptoms that persist, then you wonder about it. And the symptoms have to start in childhood. ADHD can be diagnosed at any time, but the symptoms, there has to be some symptoms in childhood. And importantly, the symptoms have to cause impairment in several settings. And impairment is really the key, meaning they're struggling in life. If it's a child in school, usually, but also at home or socially. If it's an adult, it means struggling in their relationships and struggling at work. So there has to be impairment. And then this is one of the requirements for a good evaluation is before even considering ADHD, you have to rule out other reasons that they have it, whether there are psychiatric or social or environmental factors that are causing the symptoms, then that may not be ADHD. So that's how we define the disorder. And I want to come back to kids because, again, when we think about ADHD, we think of it as a childhood disorder, at least initially. And these are some kids from our summer treatment program for ADHD from a few years ago. And you can see they're mostly boys. They're silly, happy, goofy boys. Most of our symptoms really fit better with young kids. So when you talk about adolescents or adults, the symptom lists don't work really well by themselves. So we add different descriptions to help us. So ADHD is a disorder that occurs in all age groups. In terms of how prevalent it is, well, you all know that it's very prevalent. Typical studies show that in the community, 8 to 10% of children have ADHD. In children, it's more prevalent in boys, although the gender ratio has changed somewhat over the years, but still more prevalent in boys. And when you get to adolescents, the gender ratio evens out, and in adults, it evens out. If you have 100 7-year-olds with ADHD, 60 to 70% will still meet full criteria as adolescents, and 50 to 60% will have ADHD as adults. In terms of adult prevalence, usually 4% is what we quote, and the biggest group that's untreated are adults with ADHD. After COVID, there's been a marked increase in adolescents with ADHD that have been diagnosed. The general trend of ADHD symptoms is that attention problems tend to be the most stable and the most persistent. And as you get older, you see fewer impulsive symptoms and fewer hyperactivity symptoms. So that makes it harder to diagnose in adolescents and in adults because you don't see the physical hyperactivity. So I was talking before about how the symptoms don't really fit adults really well. They kind of morph from inattention, like completing work, to difficulties with like time management and kind of executive functioning. And you see adults with ADHD that have this pattern of procrastinating and then feeling super stressed and needing those kind of time limits to get things done. But the attention symptoms are kind of much more common in adults with ADHD. Hyperactivity symptoms, they become more mental hyperactivity or verbal hyperactivity, difficulty settling down, feeling uncomfortable when they have to sustain their attention, long meetings, getting bored easily. That's what you hear from adults. And the impulsivity, a lot of it morphs into emotional lability. Not being able to control their frustration, and then making impulsive decisions. And even though it's less frequent, impulsive decisions in adults with ADHD can have devastating consequences. I should also mention adolescents with ADHD. So let's just talk about the developmental impact of untreated ADHD. So think of a preschool child. Preschoolers usually display hyperactivity, and that's what gets them to be identified. And behavioral problems, they elope, they might be aggressive. And then when they get to kindergarten or first grade, I always think of like Dennis the Menace, these silly, goofy kids that are really kind of cute and kind of funny, unless you're them. Because what happens is over time, other kids don't want to be around them. These are the kids that the teacher is always watching, and you don't want to be next to the child that's always being watched or going to get in trouble. And they're at risk to perform poorly academically, to have learning problems. And then when they become 10 or 11, they realize they're not doing well at school, and they start becoming demoralized. You see the self-esteem issues. And then in adolescence, in high school, they really have a hard time because they know they're not doing well academically. They know that they're not doing well socially. Their families are mad at them. And the only group that will accept them is the substance abuse special interest group, which is a major risk factor. Having ADHD is a major risk factor for substance abuse. And again, this cumulative impairments associated with ADHD, they struggle at school, they struggle in college, they never finish in 4 years, they struggle with relationships. And then as adults, the same type of difficulties continue. Instead of having difficulties at school, they have difficulties at work, they have multiple jobs, they have relationship problems, and self-esteem problems. And it's not a pretty picture. Untreated ADHD is not a benign disorder, and it's not just a school disorder. Russ Barkley did these longitudinal studies of children with hyperactivity followed up into adulthood. And besides doing poor academically, much more likely to have legal problems, much more likely to have medical problems, sexually transmitted diseases, unwanted, unplanned pregnancies, very high rates of these negative consequences. More recently, he's done work looking at lifespan, showing that individuals with ADHD have a 4 to 5 year lower life expectancy, mainly due to cardiovascular risk factors and suicide, which are much more common in people with ADHD. So I think of ADHD as a biological disorder, although it's certainly exacerbated by environmental factors. It's not a simplistic dopamine deficient disorder like we used to think of it. But when you think about all of the symptoms that are involved in ADHD, cognitive factors like attention, behavioral factors, reward, arousal, a contemporary view is thinking that there are multiple neurocircuits and multiple neurotransmitters that are involved in ADHD, besides dopamine and norepinephrine. And disruption or delays in any of these circuits can result in a variety of ADHD symptoms. This is one of my former teachers, the late Dr. Dennis Cantwell, who was a child psychiatrist and a soccer coach of ADHD kids. And Denny did these studies of adopted children, comparing their adoptive parents to their biological parents. And what he showed was that being adopted is a major risk factor for ADHD. I think 42% of children who were adopted in North America had ADHD at that time, and really highlighting the familiality of ADHD. And since then, we've learned that if you have a child that has ADHD, there's a 20 to 30% chance that there's a parent who also has ADHD. And the parent might be untreated, and that really has significant implications. So there's been a lot of research trying to understand what is herited in terms of ADHD and what puts you at risk. So when we look at ADHD symptoms, this is a meta-analysis that Steve Ferrone did just of twin studies. It turns out that the heritability of ADHD symptoms is about 0.75. So it's really high. It's similar to height. So a big predictor of having ADHD symptoms is having a parent that has ADHD symptoms. The heritability of the disorder, however, is much lower, again, because the disorder includes many more factors. So when you have a child with ADHD, you have a suspicion that the parent has ADHD, but we've also found that parents of children with ADHD have other problems. This is a study that I did with colleagues when I was at the University of Chicago, where we looked at the parents of kids that came to our ADHD clinic, and we compared them to parents of children with Down syndrome. And the clinics were very similar in terms of socioeconomic status. And it didn't matter what we looked at: alcoholism, substance abuse, depression, delinquency, learning disabilities, and ADHD. For everything we looked at, the parents of kids with ADHD were much more at risk. So again, this highlights when you're working with a child with ADHD, you're going to run into all these other factors that are going to affect how you treat the child. And the main point, I think, of this is that ADHD is not a single childhood disorder that is just, if you just treat the child, you're done. You really need a family perspective. I've been working for the last 15 years with Andrea Cronus-Toscano at University of Maryland in understanding multiplex ADHD families better. Those families where a child has ADHD and a parent has ADHD. And what we've learned is that if the parent has ADHD, there's going to be more likely higher rates of family conflict, less cohesion, more negativity, and that treatment of the child is going to be more complicated. Because when you think about how we treat childhood ADHD, whether it's with medication or with behavioral treatment or even working with the schools, the majority who delivers that treatment, it's usually the parent who arranges the appointments, who picks things up. And if that parent has ADHD, they're much less likely to get consistent treatment. So this is Charles Bradley, and he's the father of pediatric psychopharmacology. Dr. Bradley worked at a residential treatment center in Providence, Rhode Island. And he made the accidental discovery. He was trying to treat headaches. And what he found was that if he gave these children with hyperactivity and behavior problems Benzedrine, 3/4 of them displayed dramatic improvements in behavior. The kids called them arithmetic pills because they could do arithmetic. And about 25% didn't respond or had sleep problems. But this was like the first discovery that stimulants helped children with their attention and behavior. 20 years later, after methylphenidate was invented, Keith Connors, who's on the left, and Leon Eisenberg, who were Johns Hopkins, did the first scientific study of stimulant trials in then they were hyperactive children. And what they showed was that methylphenidate dramatically improved attention and reduced hyperactivity and impulsivity. And another major finding was that they developed the Connors rating scales. I think of the Connors rating scales for ADHD as similar to what Binet did for IQ and intellectual disability, having a way to quantify symptoms and measure treatment response. And that's really, really helped our science to have those tools. And then here's Russ Barkley again. And he did this study in the late 70s, looking at methylphenidate and parent-child interaction. So he gave hyperactive children either methylphenidate or placebo. And what he did was he measured their interactions with their parents. And what he found was that not only did the methylphenidate help the children, but the parents were more positive and more relaxed, and they had fewer commands and negative behaviors, kind of demonstrating the impact of treating ADHD on families. And he's done, and others have done similar studies looking at the impact of treating a child with ADHD on teachers, showing significant bidirectional effects. Now, some of my work has been looking at some of the longer acting medicines used for ADHD. This is a study of oros methylphenidate in kids with combined type ADHD. And this is a rating scale. The red is inattention and the green is hyperactivity. I don't know if you can see my pointer, but at baseline, there are 2 standard deviations above the mean in terms of hyperactivity and inattention. Placebo, they're a little bit better. But at low dose, they're quite better, but still in the clinical range. If we say the normal range is 55 to 50, they got there at the higher dose. And this shows a linear dose response. So the higher the dose, the greater the impact on ADHD symptoms. But we also see an inverse dose response curve in terms of tolerability. So this is sleep, here defined as insomnia, taking over 30 minutes to fall asleep. And at low dose and placebo, there's no effect. But when you get to medium and high doses, up to 1/4 of children will display nightly insomnia. So in treating ADHD, you want to find the optimal dose that helps them without causing significant tolerability problems. And then just in terms of treating ADHD, usually we don't treat just the ADHD, just like we don't evaluate children just for ADHD, because most people that have ADHD have other problems or other disorders. ADHD simplex is relatively rare. About 70% of children with ADHD, for example, have a comorbid psychiatric or developmental disorder. In children, the most common comorbid problems are speech and learning or behavior, like oppositional defiant disorder or conduct disorder. In adults, the most common comorbid conditions are emotional disorders, mood or anxiety, or substance use disorder. But there are many disorders that overlap with ADHD and many that co-occur. And when you evaluate, then you want to identify these other disorders and then come up with a treatment plan for which order and how you're going to treat them. So to summarize, ADHD is common in all age groups. My colleague, Maggie Sibley, has done really important work on the outcome of ADHD in adults, showing that the course often fluctuates, and but that many do have persistent and fluctuating impairment. Clearly, ADHD runs in families, And the main neurotransmitters that have been involved or that we've looked at are norepinephrine and dopamine, because the medicines we use to treat ADHD involve reuptake of norepinephrine and dopamine. And for almost all people with ADHD, school is a very treacherous place. And we do all we can to help them through school with a little bit of self-esteem. So now I'm going to switch to talk about treatment. And the disappointing news is we haven't really moved the needle too much in 60 years. Even though, now we have numerous medications and we have numerous studies, and we understand the mechanism of action of these medicines, we really mainly have short-term studies, and we haven't demonstrated that we can do a good job of treating the chronic and cumulative impairments associated with ADHD. And we don't really understand the tolerability that leads to people discontinuing treatment for ADHD. And I think what we need to do is we need to shift to understanding tolerability and promoting adherence. And the idea of treating ADHD is like with monotherapy, with one medicine for a short period of time. I think we need to shift to viewing ADHD as a chronic disorder whose symptoms and impairments vary. And at various times, they're going to need various combinations of treatment. And then how to sequence those treatments is what we need to learn. So I've talked about medication. The other treatment that's often delivered to kids with ADHD is behavioral interventions. And the behavioral interventions really target impairment in different settings, typically home and school. And there are interventions like parent training, school interventions like daily report cards, preferential seating. There are also studies, especially with adolescents, that focus on organizational skills training. And those are the main treatments that have developed, that have displayed some evidence. There are a lot of things that have been developed that you can purchase that have not demonstrated efficacy. Individual therapy or counseling, for example, social skills training. There's some cognitive training. There's some applications for ADHD, and most of these have been very disappointing in terms of their outcomes. So now I want to talk a little bit about new directions and some of, I guess, our lab, what we've focused on. I have a strong interest in the relationship between ADHD treatments and sleep. We used to think of ADHD as an 8-hour disorder and then a 12-hour disorder when we would treat them with longer acting stimulants. But we found that the longer you treat ADHD, if you're going to have a tolerability issue, then that's going to be longer too. And I'm thinking about, I was in China once and I heard about these children that were treated with 2 12-hour stimulants because their day was just so demanding. But you don't want to sacrifice nights in order to have good days. Using stimulants exclusively in someone that's not sleeping is going to lead to chronic sleep deprivation and other problems. And so when we're evaluating someone for ADHD, we always take a 24-hour perspective. And you want to find the optimum treatment where a child gets a good night's sleep and can be attentive during the day. And there's a lot of variation among individuals in terms of both how they respond to medication and exercise and sleep and figuring out that balance. But certainly the foundation of ADHD treatment is having adequate sleep and adequate nutrition. The second, I think, major theme of our research has been treating ADHD as a family disorder. And we've been doing this study called the TPAC study, the treating parents and children with ADHD, where we look for young children who have ADHD symptoms, who are not taking medicine, 4 to 8-year-olds, who have a parent that has ADHD symptoms that are not taking medicine. And in the TPAC study, what we do is we evaluate the parent and child. And if they're eligible, if the parent has ADHD, then we provide treatment. And half the parents get a medication trial with a stimulant and then parent training that's individualized for having a parent with ADHD, and the other half gets parent training. So we're trying to figure out if the parent is treated, does that make a difference? And what is the impact of treating the parent first before the child with ADHD? because treatments in preschoolers with ADHD are just not as effective as they are in older children. Younger children are more likely to have tolerability issues. And so we're evaluating this approach. And this is a study that it's ongoing and we're actively recruiting for. I'm also interested in predictors of ADHD treatment response. And we have a study called the SES1 study. SES1 is an enzyme. It's the major metabolizing gene for methylphenidate and other medicines. And we're looking for people that have various variants of the SES1 gene and testing how they respond to methylphenidate. So that's a study that's almost done, but we're still looking for a few participants in that study. And then we just started a new study of trigeminal nerve stimulation. This is a novel treatment for ADHD where children wear, looks like a Band-Aid on their forehead at night. And it's kind of like a TENS device in terms of it delivers a low level of electrical stimulation to the trigeminal nerve. And this has been cleared by the FDA, and we're trying to evaluate in more detail the mechanism, how it works and who it works for. And so this is our study we call ADHD GEMS. And then in our clinical programs, in the Pearl Clinic, we're very interested. We embrace the collaborative care and working with our pediatric partners. And we're trying to identify gaps in care. Right now, post-COVID, there are many, many gaps and long waiting lists. But one of the biggest gaps are in adolescents with ADHD, this key group. And adolescents with ADHD, again, are at risk for so many things, and we have less treatment available for them. It turns out that the most common age to discontinue an ADHD medicine is age 13. And so we're trying to develop a model of care and an intervention called the ADHD checkup, which uses shared decision-making between the adolescent and their parent to do an evaluation and using motivational interviewing to help identify treatment targets to see if we can increase engagement of the adolescent treatment. And this is a new grant that we've applied for, and we're hoping that we'll be able to do. So let me just summarize a few things. So ADHD usually doesn't come by itself. It's associated with many different problems, psychiatric, developmental, and medical problems in the child, and parental ADHD and other psychiatric disorders, including just the cumulative stress of raising a child with ADHD. And then rather than thinking of ADHD as a childhood disorder, similar to an infectious illness, and not thinking of it as a chronic disorder, like diabetes that needs medicine for the rest of your life, think of it as a developmental disorder whose symptoms change over time, but some of the impairments, especially when you fall behind, can be very chronic. And think of it as a 24-hour disorder that we have effective treatments for, but don't really understand how to put those treatments together in the individual case. And then thinking about ADHD treatments, it's not a question of pills or skills or accommodations. It's really a combination of really all those things, or multimodal treatment, and how you order them. What do you do first? Do you start with accommodations like a 504 plan and then go to a medication trial? Do you do parent training first? I think we need better decision rules of deciding who gets different treatments to increase the efficacy and to reduce waste. And we know that there are certain families that need more. I mentioned the multiplex ADHD families. And that's really getting us to personalized medicine. How we can understand how demographic, clinical, and biological, especially genetic factors, contribute to variability in ADHD, how it presents, and then that can help us decide on treatment. And then rather than focusing on just, are they better now, which is short-term efficacy, which we have many medicines and other interventions that have demonstrated short-term efficacy, but not continued effectiveness. So that for that, we need to understand tolerability and adherence. And I think studying groups like non-responders shows much promise. And then huge issue, because ADHD treatment varies so much between regions, and countries and socioeconomic classes. Children with more severe ADHD are the least likely to be treated. We see much more mild ADHD, people that have access to care. So what can we do with our healthcare system to improve equitable access to evidence-based treatments? So many people get treatments for ADHD that don't work. I mean, I wish I had a nickel for everyone that said to give them a fidget or have them sit on a special chair, as opposed to evidence-based behavioral or teacher training or medication trials. For those that might be interested in the TPAC study, I just want to mention that again. This is for 3 to 8-year-old children who are not taking medicine. If the parent is not taking medicine and they think that they have some symptoms, we'd be happy to see them in the TPAC study. And in the GEM study, for 7 to 12-year-olds, a child suspected of having ADHD, they get an evaluation. Can't be taking medication during the study, though. Oh, this is what the GEM study looks like in terms of the trigeminal nerve stimulator. And I want to, last slide, this is a nice resource for people that are just looking like a summary of what we've learned about ADHD. The World Federation has developed this review article and this website of all the evidence from all the meta-analyses in terms of what we've learned about ADHD.